Module 7, Neurologic Disorders. Regulation 49 CFR 39.41 reads, "A person is physically qualified to drive a commercial motor vehicle if that person has no established medical history or clinical diagnosis of rheumatic, arthritic, orthopedic, muscular, neuromuscular, or vascular disease which interferes with his or her ability to control and operate a commercial motor vehicle safely. If that driver has no established medical history or clinical diagnosis of epilepsy or any other condition which is likely to cause loss of consciousness or any loss of ability to control a commercial motor vehicle. If the driver has no mental, nervous, organic, or functional disease or psychiatric disorder likely to interfere with his or her ability to drive a commercial motor vehicle safely." Commercial motor vehicle drivers must be able to sustain vigilance and attention for extended periods in all types of traffic, road, and weather conditions. Neurologic demands of driving include cognitive demands, sustained vigilance and attention, quick reactions, communication skills, appropriate behavior, and physical demands, exemplified by coordination. Most individuals have experienced the symptoms of headaches, vertigo, and dizziness. While generally inconsequential, these symptoms may constitute a problem for the driver of a commercial motor vehicle. Risk from headaches. Headache and chronic nagging pain may be present to such a degree that certification for a commercial motor vehicle driver is inadvisable, and the medication used to treat headaches may further interfere with safe driving. Complaints should be thoroughly examined when determining the overall fitness of the driver. Disorders with incapacitating symptoms, even if periodic or in the early stages of disease, warrant the decision to not certify the driver. Risk from vertigo and dizziness. Multiple conditions may affect equilibrium or balance, resulting in acute incapacitation or varying degrees of chronic spatial disorientation. Types of vertigo and dizziness with incapacitating symptoms, even if periodic or in the early stages of disease, warrant the decision to not certify the driver when symptoms interfere with one or more of the following: cognitive abilities, judgment, attention, concentration, sensory or motor function. Risk from seizures and epilepsy. Safety is the major reason the driver with epilepsy or seizures is restricted from commercial driving, as loss of consciousness endangers the driver and the public. It is important to understand that the FMCSA medical guidance distinguishes between epilepsy, which is defined as 2 or more unprovoked seizures, a single unprovoked seizure, a provoked seizure. When evaluating a driver who notes a history of seizure, the examiner must determine into which category the seizure falls so as to approach the certification decision correctly. The physical and mental demands of commercial driving expose seizure-prone individuals to conditions that may increase the risk for seizures and may interfere with management of seizures, including inconsistent access to medical evaluation and care for acute problems, delays in replacement of anticonvulsant medication if lost or forgotten. The length of time an individual is seizure-free and off anticonvulsant medication is considered the best predictor of future risk of seizures. Other considerations include the underlying cause of the seizure, the area of the brain affected by disease or injury. As the medical examiner, your fundamental obligation during the neurological assessment is to establish whether a driver has a neurological disorder that increases the risk for sudden death or incapacitation, thus endangering public safety. FMCSA medical guidance recommends that diagnosis and evaluation of neurological conditions be performed by an appropriate specialist, usually a neurologist or a neurosurgeon. During the physical examination, you should ask the same questions as you would any individual who's being assessed for neurological concerns. Per regulations, you must review and discuss with the driver any yes or not sure answers. Does the driver have seizures, epilepsy, or use of anticonvulsant medication, a history of head or brain injuries, disorders, or illnesses, episodes of loss or altered consciousness, episodes of fainting or dizziness, a history of stroke with residual paralysis, spinal injury or disease with residual deficits. Current regulations state that you must evaluate on physical exam if the driver has compromised equilibrium, coordination, or speech pattern, asymmetrical deep tendon reflexes, abnormal patellar and Babinski reflexes, sensory abnormalities, positional abnormalities, ataxia. Regulations state that you must document discussion with the driver about any affirmative history, including, if available, onset date and diagnosis, medications and their dose and frequency, any current limitations, any potential negative effects of medication use, including over-the-counter medications while driving, any abnormal findings noting the effect on the driver's ability to operate a commercial motor vehicle safely, necessary steps to correct the condition as soon as possible, particularly if the untreated condition could result in more serious illness that might affect driving, any additional neurological tests and evaluation. Medical fitness for duty includes the ability to perform strenuous labor. Medical fitness for duty also requires the driver to be free of any neurological residual limitations sufficiently severe to interfere with cognitive abilities, judgment, attention, concentration, vision, physical strength, agility, reaction time. Specific advisory criteria and guidance. Seizures. Per the FMCSA, epilepsy is a chronic functional disease characterized by seizures or episodes that occur without warning, resulting in loss of voluntary control, which may lead to loss of consciousness and/or seizures. Therefore, the following drivers cannot be qualified: a driver who has a history of epilepsy, a driver who has a current clinical diagnosis of epilepsy, a driver who is taking anti-seizure medication. Current FMCSA advisory criteria allow that for a driver with a history of epilepsy or a seizure disorder, the medical examiner may certify the driver if the driver is both off anti-seizure medication and seizure-free for 10 years or more. The examiner should be aware that in such cases, it is probably most prudent to have the driver apply for a seizure exemption from the FMCSA instead of having the examiner accept the liability and responsibility for certifying such a driver. However, it is important to know that if a driver with a history of epilepsy does meet the criteria of being off anti-seizure medication and seizure-free for 10 years or more, you do have discretion to certify. An unprovoked seizure occurs in the absence of provocative causes. While individuals who experience a single unprovoked seizure do not have a diagnosis of epilepsy, they are clearly at higher risk for having further seizures. Approximately 30 to 50% of patients with a first seizure will have a second unprovoked seizure. Following an initial unprovoked seizure, the commercial motor vehicle driver should be seizure-free and off anticonvulsant medication for at least 5 years to distinguish between a medical history of a single instance of seizure and epilepsy. A second unprovoked seizure, regardless of the elapsed time between seizures, would constitute a medical history of epilepsy, and the driver would no longer meet the physical requirements of Regulation 49 CFR 391.41 allowing certification. If the driver has a history of a single provoked seizure, that is, there is a known reason for the seizure, then the certification waiting period and certification length will depend upon the underlying causative diagnosis. This will be discussed in the context of individual diagnoses later in this module. The Federal Seizure Exemption. The FMCSA will accept applications for an exemption from the seizure regulation on an individual case-by-case basis, allowing drivers who take anti-seizure medication from the regulation, allowing them to operate a commercial motor vehicle in interstate commerce for a period of 2 years. The FMCSA is clear to point out that it is not granting exemptions to drivers with recent seizures and that each case is evaluated on an individual basis. The FMCSA takes into consideration such factors as the cause of the individual seizure, date of last seizure, and treatment regimen. Drivers covered by the exemptions have demonstrated that they are unlikely to have a seizure and their medical condition does not pose a risk to public safety. The exemption preempts state laws and regulations and may be renewed. Criteria for a seizure exemption. Exemption requirements. The exemption is contingent upon the driver maintaining a stable treatment regimen and remaining seizure-free during the 2-year exemption period. The driver must submit annual reports from the treating physician to attest to the stability of treatment and the driver has remained seizure-free. The driver must have an annual medical examination by a medical examiner. The FMCSA describes 3 groups of seizures when considering a seizure exemption application: epilepsy or seizure disorder diagnosis, a single unprovoked seizure, a single provoked seizure. Epilepsy. The driver with a diagnosis of epilepsy needs to be seizure-free for 8 years on or off medications. If using medications, the regimen must be stable for 2 years, that is, no change in medication dosage or frequency. The driver must be recertified every year. Federal seizure exemption requirements for the driver with a single unprovoked seizure, that is, no known trigger for the seizure. Seizure-free for 4 years, on or off medications. The medication regimen must be stable for 2 years. The driver must be recertified every 2 years. Federal seizure exemption requirements for a driver with a single provoked seizure. The FMCSA divides such applications into low-risk and high-risk groups. Low-risk factors for recurrence include seizures caused by medications, such as a lidocaine reaction, seizures from non-penetrating head injury with a loss of consciousness less than 30 minutes, seizures due to a metabolic derangement not likely to recur, or from alcohol or illicit drug use withdrawal. Certify the driver for 1 year, and then the driver can recertify yearly. Moderate to high risk provoked seizures. These are seizures caused by non-penetrating head injury with loss of consciousness or amnesia greater than 30 minutes, or penetrating head injury, intracranial hemorrhage associated with stroke, trauma, or any other etiology, brain infections, post-operative complications from brain surgery with significant hemorrhage, brain tumor, or stroke. For a single provoked seizure resulting from a moderate to high risk factor, certification via a federal exemption may be considered if the driver has been seizure-free, on or off medications for a minimum of 8 years. If on medications, the medication regimen must be stable for a minimum of 2 years. The driver may apply for recertification every year. If the medical examiner is unsure about whether to qualify a driver with a history of epilepsy or a seizure disorder, or of a single non-epileptic seizure or episode of loss of consciousness, the medical examiner may refer the driver to the FMCSA for evaluation under the Federal Seizure Exemption Program. Childhood febrile seizures. Febrile seizures occur in from 2 to 5% of children in the United States before 5 years of age and seldom occur after 5 years of age. From a practical standpoint, most individuals who have experienced a febrile seizure in infancy are unaware of the event, and the condition would not be readily identified through routine screening. Most of the increased risk for unprovoked seizure is appreciated within the first 10 years of life. A driver with a history of seizures that are limited to childhood febrile seizures may be certified for a period of up to 2 years. Traumatic brain injury. Traumatic brain injury is an insult to the brain caused by an external physical force, which may produce a diminished or altered state of consciousness, including coma, resulting in long-term impairment of cognitive or physical function. Disturbances of behavioral or emotional functioning may result in total or partial disability or psychological maladjustment. Many people with TBI suffer loss of memory and reasoning ability, experience speech or language problems, and exhibit emotional and behavioral changes that are medically disqualifying for commercial driving. TBI is classified by depth of dural penetration and duration of loss of consciousness. The latest FMCSA definitions of the classes of TBI are: severe head injury penetrates the dura and causes a loss of consciousness lasting greater than 24 hours. There is a high risk for unprovoked seizures, and the risk does not diminish over time. Moderate head injury does not penetrate the dura, but causes an alteration of consciousness lasting greater than 30 minutes, but less than 24 hours, or a skull fracture and 0 to 30 minutes of alteration of consciousness or post-traumatic amnesia. Mild head injury results in alteration of consciousness for less than 30 minutes. The length of time an individual is seizure-free and off anticonvulsant medication is considered the best predictor of future risk of seizures. Therefore, for the entire waiting period before being considered for certification, the driver must be both seizure-free and off anticonvulsant medication prescribed for control of seizure. Surgical procedures involving dural penetration have a risk for subsequent epilepsy similar to that of severe head trauma. Individuals who have undergone such procedures, including those who have had surgery for epilepsy, should not be considered eligible for certification. The waiting period per the most recent FMCSA Medical Expert Panel report is as follows. For mild TBI, 1 month if there was no loss of consciousness. For mild TBI with loss of consciousness, there is a 3-month waiting period. For moderate TBI, there is a 3-year waiting period before certification. Of course, the examiner needs to ensure that the driver is asymptomatic and there have been no seizures since the TBI. Certify the driver if the driver with a mild or moderate TBI has completed the minimum waiting period seizure-free and off anticonvulsant medication, a normal physical exam, neurological examination including neuro-ophthalmological evaluation and neuropsychological testing, clearance from a neurologist who understands the functions and demands of commercial motor vehicle driving. The driver should have an annual medical examination. Do not certify if the driver has sustained severe TBI either with or without early seizures. Transient ischemic attack. A TIA is an episode of focal neurological dysfunction reflecting inadequate blood supply to one portion of the brain. The attack usually lasts more than a few seconds but less than 20 minutes. In exceptional cases, the symptoms can persist for up to 24 hours. Resolution of symptoms is complete. At the time of physical exam, the driver is usually normal. However, a TIA is an important warning for a potentially severe stroke or other vascular event. The risk of recurrent events is highest during the first few weeks and months following the TIA, declining by year 1 to less than 5% per year. The risk of recurrent strokes may be lowered by medical or surgical interventions. The medical examiner determines certification on a case-by-case basis considering the interval history, general health, neurological examination, and compliance with the treatment program. The minimum waiting period for certification is 1 year. The maximum certification is 1 year. On a case-by-case basis, obtain additional tests or consultation to adequately assess driver medical fitness for duty. Certify if the driver has completed the minimum waiting period seizure-free and off anticonvulsant medication, has a normal physical exam and normal neurological examination including neuro-ophthalmological evaluation and neuropsychological testing, and has clearance from a neurologist who understands the functions and demands of commercial driving. Embolic and thrombotic strokes. More than 3 million individuals have survived a stroke, and it is a major cause of long-term disability. Embolic and thrombotic cerebral infarctions are the most common forms of cardiovascular disease. Risk for complicating seizures is associated with the location of the lesions. Cerebellum and brainstem vascular lesions are not associated with an increased risk for seizures. Cortical and subcortical deficits are associated with an increased risk for seizures. Evaluation by a neurologist is necessary to confirm the area of involvement. Drivers with embolic or thrombotic cerebral infarctions will have residual intellectual or physical impairments. Fatigue, prolonged work, and stress may exaggerate the neurological residuals from a stroke. Most recovery from a stroke will occur within the first year of the event. Approximately 12% of individuals suffering from an occlusive cerebral vascular insult resulting in a fixed neurological deficit will experience a seizure at the time of the insult. Unprovoked seizures will occur within the next 5 years in 16% of all individuals with an occlusive vascular insult. This rate seems not to be modified significantly by the occurrence of early seizures. The recommended waiting period following a stroke depends upon the location of the stroke, as this determines the risk for subsequent seizures. The waiting period is a minimum 1 year if not at risk for seizures, that is, the stroke is located in the cerebellum or brainstem, i.e. posterior circulation lesions. For strokes that put the driver at risk for subsequent seizure, that is, cortical or subcortical deficits, i.e. a stroke resulting from a lesion in the anterior or middle cerebral circulation, the long-standing recommendation has been a minimum 5-year waiting period. This recommendation dates back to the 1988 FMCSA Conference on Neurological Disorders. In 2009, the FMCSA MEP reviewed available evidence and concluded that a 1-year waiting period for such drivers would be appropriate. However, the FMCSA Medical Review Board, upon reviewing this report, did not approve the change and recommended continuing the 5-year waiting period. Therefore, in actual practice, there is some evidence to support either a 1-year or 5-year waiting period. However, if asked on the NRCME exam, select the 5-year waiting period as your answer. Regardless of the stroke location, the maximum certification is 1 year. Certify if the driver with a history of stroke has completed the appropriate waiting period, has a normal physical exam, a normal neurological examination including neuro-ophthalmological evaluation and neuropsychological testing, has no neurological residuals or, if present, residuals of a severity that does not interfere with the ability to operate a commercial motor vehicle safely. the driver requires clearance from a neurologist who understands the functions and demands of commercial driving. Intracerebral and subarachnoid hemorrhages. Intracerebral hemorrhage results from bleeding into the substance of the brain, and subarachnoid hemorrhage reflects bleeding primarily into the spaces around the brain. Bleeding occurs as a result of a number of conditions, including hypertension, hemorrhagic disorders, trauma, and cerebral aneurysms, neoplasms, AV malformations, and degenerative or inflammatory vasculopathies. The risk for seizures following intracerebral and subarachnoid hemorrhages is associated with the location of the hemorrhage. Cerebellar and brainstem vascular hemorrhages are not associated with an increased risk for seizures. Cortical and subcortical hemorrhages are associated with an increased risk for seizures. Appropriate evaluation by a neurologist is required to confirm the area of involvement. The recommendations for intracranial and subarachnoid hemorrhage parallel recommendations for strokes. The waiting period is a minimum 1 year if not at risk for seizures, that is cerebellar or brainstem vascular lesions, and a minimum 5 years if at risk for seizures, cortical or subcortical deficits. The maximum certification period is 1 year. Certify the driver with a history of intracranial or subarachnoid hemorrhage if the driver has completed the appropriate waiting period, has a normal physical exam and normal neurological exam including neuro-ophthalmological evaluation and neuropsychological testing, has no neurological residuals or, if present, residuals of a severity that do not interfere with the ability to operate a commercial motor vehicle, and the driver has clearance from a neurologist who understands the functions and demands of commercial driving. CNS tumors. The NRCME certification exam does not typically ask questions regarding guidance for CNS tumors, but we include this section for completeness to aid in your daily practice of DOT exam certifications. The CNS is the seat of our intelligence and emotions, and an affliction of the CNS impacts everyday functioning in a direct and visible manner. Brain tumors may alter cognitive abilities and judgment, and these symptoms may occur early in the course of the condition. Sensory and motor abnormalities may be produced both by brain tumors and by spinal cord tumors, depending on the location. For some benign tumors, certification may be possible after successful surgical treatment. As previously discussed, the length of time an individual is seizure-free and off of anticonvulsant medication is considered the best predictor of future risk of seizures. Therefore, for the entire waiting period before being considered for certification, the driver must be both seizure-free and off anticonvulsant medication prescribed for control of seizures. The waiting period is a minimum 1 year post-surgical removal of infratentorial meningiomas, acoustic neuromas, pituitary adenomas, spinal benign tumors, benign extraaxial tumors. The waiting period is a minimum 2 years post-surgical removal of benign supratentorial tumors, spinal tumors. The maximum certification period is 1 year. Certify the driver with a CNS tumor if the driver has completed the appropriate minimum waiting period, has a stable non-progressive deficit or no neurological deficit, has imaging that shows no tumor. If the driver has a history of seizures as a complication of the tumor, use the appropriate seizure guidelines. Since meningiomas may be multiple, residual examinations must show no evidence of recurrent or new tumors. Evaluation should be performed by a neurologist or physiatrist who understands the functions and demands of commercial driving. Dementia is a progressive decline in mental functioning that can interfere with memory, language, spatial functions, higher-order perceptual functions, problem-solving, judgment, behavior, and emotional functions. Alzheimer's and Pick's diseases both cause dementia and have symptoms that are incompatible with safe driving. Neither disease has a specific diagnostic test, with mild symptoms typically present for years before the diagnosis is made. Alzheimer's is the most common degenerative disease. The rationale for making a decision not to certify when a diagnosis of dementia is present includes: there are no current data providing evidence that a driver with diagnosed dementia can drive a commercial motor vehicle safely. The disease rate of progression is variable. Do not certify if the driver has a diagnosis of dementia. Infections of the central nervous system. The guidelines for CNS infection consider diagnosis and whether or not the driver has a history of early seizures with the condition. Aseptic meningitis is not associated with any increase in risk for subsequent unprovoked seizures. Therefore, no restrictions should be considered for such individuals. A driver with a current clinical CNS diagnosis or signs and symptoms of a CNS infection should not be considered for certification until the etiology is confirmed and treatment has been shown to be adequate, effective, safe, and stable. The waiting period is a minimum 1 year seizure-free and off anticonvulsant medications following bacterial meningitis without early seizures, viral encephalitis without early seizures. A minimum of 5 years seizure-free off anticonvulsant medication following bacterial meningitis with early seizures. A minimum 10 years seizure-free and off anticonvulsant medication following viral encephalitis with early seizures. Certify if the driver has a history of aseptic meningitis, bacterial meningitis, and has completed the appropriate recommended waiting period, viral encephalitis, and has completed the appropriate recommended waiting period. The maximum certification period is 2 years. Do not certify if the driver has a current CNS infection. Vertigo and dizziness. The normal ability to maintain balance and orientation while operating a commercial motor vehicle depends upon peripheral nervous system sensory input from 3 major systems and the appropriate motor integration in the CNS. The 3 peripheral nervous system sensory systems are vestibular, visual, and proprioception. Inappropriate interactions of these systems or interactions within the CNS may produce an unsafe degree of vertigo or dizziness that endangers the health and safety of the driver and the public. The most common medications used to treat vertigo are antihistamines, benzodiazepines, and phenothiazines. Use of either benzodiazepines or phenothiazines for the treatment of vertigo would render the driver medically unqualified. Special consideration should be given to the possible sedative side effects of antihistamines. The medical examiner should determine if these drugs produce sedation in the individual driver. The waiting period is a minimum of 2 months asymptomatic with a diagnosis of benign positional vertigo, acute and chronic peripheral vestibulopathy. Certify if the driver has a diagnosis of benign positional vertigo and has completed the appropriate symptom-free waiting period, acute and chronic peripheral vestibulopathy and has completed the appropriate symptom-free waiting period, a medical condition of a nature and severity that does not endanger the health and safety of the driver and the public. Do not certify if the driver has a diagnosis of benign positional vertigo and has been symptomatic within the past 2 months, acute or chronic peripheral vestibulopathy and has been symptomatic within the past 2 months, Meniere's disease, labyrinthine fistula, non-functioning labyrinths. And now to review a summary of neurological waiting periods. Seizure waiting periods. The driver must complete the minimum waiting period seizure-free and off anticonvulsant medications. Waiting period of 10 years. History of epilepsy, viral encephalitis with early seizures. Waiting period of 5 years. A single unprovoked seizure with no identified acute change. There may be a distant cause identified. There is a possibility of an early return to driving if there is a normal neurological examination by a specialist in epilepsy who understands the demands of commercial driving and the driver has a normal EEG. Also, with a waiting period of 5 years, bacterial meningitis with early seizures. Waiting period of 2 years, acute seizure with an acute structural CNS insult. Other neurological waiting periods. The driver must complete the minimum waiting period seizure-free and off anticonvulsant medication. Waiting period of 5 years. Stroke with risk for seizures. Intracerebral or subarachnoid hemorrhage with risk of seizures. Waiting period of 3 years. Moderate traumatic brain injury. Waiting period of 2 years. Surgically removed supratentorial or spinal tumors. Waiting period of 1 year. TIA, stroke, or intracerebral or subarachnoid hemorrhage with no risk for seizures. Surgically repaired AV malformation or aneurysm with no risk for seizures. Surgically removed infratentorial meningiomas, acoustic neuromas, pituitary adenomas, and benign spinal tumors or other benign extraaxial tumors with no risk for seizures. CNS infections, for example, bacterial meningitis or viral encephalitis without early seizures. Neurological diagnoses that, according to guidance, should be disqualifying. Severe traumatic brain injury, AV malformation or aneurysm that has not been surgically repaired, dementia, Parkinsonism, cerebellar ataxia of any etiology, frequent or severe headaches that interfere with safe driving. Finally, there are two diagnoses that the FMCSA groups along with neurological conditions as they are associated with loss of consciousness: narcolepsy and idiopathic hypersomnia. Excessive daytime sleepiness is typically the first, primary, and most disabling manifestation of narcolepsy. Excessive sleepiness is chronic and may manifest as pervasive drowsiness and sub-wakefulness, frequent napping, and unexpected and overpowering sleep attacks occurring almost daily. Idiopathic hypersomnia results in sleepiness after sufficient or even increased amounts of nighttime sleep without any identifiable cause. Excessive sleepiness is generally severe and present almost daily. Unintended naps are longer than those of narcolepsy, and, unlike narcolepsy, they are typically unrefreshing. Narcolepsy and idiopathic hypersomnia are diagnosed with an overnight lab-based sleep study followed by a multiple sleep latency test performed the morning after the sleep study. There is no cure for either narcolepsy or idiopathic hypersomnia. While medications and lifestyle modifications can help ease some symptoms, an individual remains likely to lose consciousness and therefore does not satisfy the FMCSA regulatory standard for certification. Syncope. When an individual has had a single unprovoked episode of loss of consciousness, that is, the cause is unknown or there is no clear provoking trigger, that is determined not to have been a seizure, the medical examiner may certify the individual if the examiner determines recurrence of loss of consciousness or loss of ability to control a commercial motor vehicle is unlikely and the individual is not taking anti-seizure medication. The determination should be made on an individual basis by the medical examiner in consultation with the treating provider. According to the 2024 FMCSA Medical Advisory Criteria, before certification is considered, it is recommended that a 6-month waiting period elapse from the time of the episode. Clinical scenario. Gail Miller is a 44-year-old female who presents for a recertification examination. On the health history of the medical examination report form, she responds yes to muscular disease. She takes Avonex every other day. Ms. Miller was diagnosed with multiple sclerosis 3 months ago. She denies any side effects from the medication. She also denies vision and sensory symptoms, loss of balance, or headaches. She occasionally has an itch or tingling in her left upper arm. She is right-handed. She sees her neurologist monthly for follow-up and has brought copies of her neurology records. The MRI reveals plaques that are suspicious for a demyelinating disease. Her LP was normal. Her neurologist states that he is treating her for possible MS and her neurological status has remained stable. On examination, her upper extremity strength was 5/5 on the right and 4/5 on the left. Lower extremity strength was 5/5 on the right and 5/5 on the left. Reflexes are 2+ bilaterally. Her grip strength was within normal range and she did not display any balance deficiencies. The rest of the physical examination was unremarkable. What is the determination outcome? The driver meets standards, but periodic monitoring is required due to possible diagnosis and progressive nature of multiple sclerosis. Certify for 1 year. Ms. Miller's physical examination is essentially normal, other than left upper arm tingling and itching, which may represent early signs of MS. Her left arm strength is 4/5, which is still good, with prehensile grasp and pincher ability adequate to perform commercial motor vehicle driver manual hand tasks. She doesn't display all the typical symptoms of an advancing disease process. There do not appear to be any cognitive deficits, and her diagnosis is, quote, possible MS. Paul Nelson is a 57-year-old male who presents for a recertification examination. Mr. Nelson presents for, quote, renewal of my DOT card. His last FMCSA medical certificate was issued almost 2 years ago. When asked about illness in the last 5 years, he stated that, quote, I had a bleed in my head that caused a little stroke about 8 months ago. Upon further inquiry, you find that he had a left-sided brain stroke due to the, quote, bleed from an AVM, resulting in a residual right-sided hemiplegia. Mr. Nelson has not yet returned to work. Apparently, the neurosurgeon has not performed any surgical repair of the AVM at this point, and Mr. Nelson is not sure when or if a surgical procedure is to take place. He is still attending occupational and physical therapy. On exam, the driver walks with a limp, drags his right leg, and his right upper extremity hangs downward, being flaccid with mild internal rotation at the shoulder. He has motor and sensory deficits consistent with a right-sided hemiplegia. There was some question as to his short-term recallability and attention span. The rest of the examination was unremarkable. What is the determination outcome of this examination and why? Mr. Nelson was disqualified because he has had a ruptured AVM that has not been surgically treated to prevent additional bleeding. He has a right-sided hemiplegia. He exhibits cognitive impairment during the history and physical examination. Recently, the NRCME certification exam has moved away from many questions asking about neurologic waiting times, although you should expect a few, and has started focusing on general clinical questions regarding the impact of neurologic conditions on the commercial motor vehicle driver. So, for example, a common question asks what symptoms would be of most concern in a driver with a history of traumatic brain injury. Answers include symptoms such as headaches and dizziness. Of course, dizziness would be the biggest concern. This concludes Module 7.